Empiric antibiotic therapy in suspected neonatal sepsis represents a race against time where clinical judgment must drive immediate action, often before laboratory confirmation becomes available. The fundamental principle is starting antibiotics immediately when sepsis is suspected, regardless of laboratory results or culture availability. Neonatal sepsis progresses rapidly due to immature immune systems, and waiting for confirmatory testing can result in irreversible complications or death. Clinical suspicion based on risk factors or subtle signs should prompt immediate treatment. Obtaining blood cultures before antibiotic administration provides the best opportunity for pathogen identification, but this should never delay treatment. If venous access is already established, draw the culture quickly and start antibiotics immediately. However, if obtaining cultures requires time-consuming procedures or multiple attempts, begin antibiotics first and obtain cultures when possible. The choice of empiric antibiotics depends on the timing of sepsis onset, which reflects different pathogen patterns. Early onset sepsis, occurring within 72 hours of birth, typically results from maternal flora transmission. The combination of ampicillin and gentamicin provides excellent coverage for Group B Streptococcus, E. coli, and Listeria, the most common early onset pathogens. Ampicillin covers gram-positive organisms and Listeria specifically, while gentamicin handles gram-negative bacteria. Late-onset sepsis, developing after 72 hours, involves different organisms often acquired from the hospital environment. Vancomycin replaces ampicillin to cover methicillin-resistant staphylococci and coagulase-negative staph commonly found on central lines and medical devices. Gentamicin continues providing gram-negative coverage. Once culture results identify the specific organism, antibiotic therapy should be narrowed to target that pathogen specifically. This approach reduces antibiotic resistance development and minimizes disruption to normal bacterial flora. The 48-hour rule applies when cultures remain negative and the baby appears clinically well. If blood cultures show no growth after 48 hours and clinical signs have resolved or were minimal, antibiotics can be discontinued safely. This approach prevents unnecessary antibiotic exposure while ensuring adequate treatment for true infections. Hand hygiene represents the single most powerful weapon we have against healthcare-associated infections. Yet its simplicity often leads to underestimation of its critical importance in protecting our most vulnerable patients. Healthcare-associated infections remain a leading cause of morbidity and mortality in neonatal intensive care units. But proper hand hygiene can prevent up to 40% of these infections. This statistic transforms every hand hygiene opportunity into a life-saving intervention, particularly for preterm infants whose immature immune systems cannot fight off pathogens that healthy adults would easily clear. The World Health Organization's 5 Moments framework provides a systematic approach to hand hygiene timing that addresses the most common transmission pathways. Before patient contact prevents introducing pathogens from previous patients or environmental sources. This moment is crucial because healthcare workers' hands become contaminated simply by moving through the healthcare environment, touching surfaces, and caring for other patients. Before aseptic procedures becomes critical, when we breach natural barriers through procedures like central line insertion, endotracheal intubation, or wound care. These procedures create direct pathways into normally sterile body sites, making pathogen introduction particularly dangerous. After body fluid exposure protects the healthcare worker and prevents transmission of bloodborne pathogens or other infectious agents from one patient to others. This includes obvious exposures like blood or respiratory secretions, but also less obvious contacts with saliva, urine, or wound drainage. After patient contact prevents carrying organisms away from the patient to other areas of the unit. Even routine care activities like taking vital signs or positioning can contaminate hands with the patient's flora, which then spreads to other patients or environmental surfaces. After touching patient surroundings, addresses the reality that pathogenic bacteria colonize bed rails, monitors, and other equipment near patients. These surfaces serve as reservoirs that can contaminate hands even without direct patient contact. The 20 to 30 second duration for proper hand washing allows adequate time for mechanical removal and antimicrobial action. This timing ensures coverage of all hand surfaces and sufficient contact time for soap or alcohol-based solutions to destroy pathogens effectively. Achieving greater than 90% compliance requires systematic monitoring and culture change that makes hand hygiene automatic rather than optional. Hand hygiene technique determines whether this fundamental infection prevention measure actually protects patients or merely creates a false sense of security. Understanding proper technique ensures every hand hygiene opportunity delivers maximum protective benefit. Alcohol-based hand rubs represent the preferred method for most clinical situations because they provide superior antimicrobial efficacy compared to soap and water against most pathogens. The alcohol concentration must reach at least 70% to ensure effective pathogen destruction, with higher concentrations providing even better antimicrobial action. The application technique requires systematic coverage of all hand surfaces, which most healthcare workers perform inadequately. Start by applying enough product to cover all surfaces, typically 3 to 5 milliliters for average-sized hands. Rub palms together, then interlace fingers to clean between digits. Don't forget the backs of hands, fingertips, and particularly the thumbs, which are frequently missed during routine application. The 20 to 30 second duration continues until hands feel completely dry. This timing isn't arbitrary. It ensures adequate contact time for alcohol to penetrate bacterial cell walls and provides sufficient mechanical action to remove transient organisms. Cutting this process short dramatically reduces effectiveness. However, alcohol-based products have important limitations that require soap and water in specific situations. Clostridioids difficile forms spores that resist alcohol destruction, making mechanical removal through soap and water essential when caring for patients with this infection. Similarly, norovirus demonstrates reduced susceptibility to alcohol, requiring soap and water for effective removal. Visible soiling always requires soap and water because alcohol cannot clean away organic matter that may harbor pathogens underneath. The physical debris must be removed before antimicrobial action can reach the organisms beneath. After removing contaminated gloves, soap and water may be necessary depending on the degree of contamination. Heavy contamination can penetrate gloves or contaminate hands during removal, requiring more thorough cleaning than alcohol rub provides. Nail and jewelry policies exist because these areas harbor organisms that resist standard cleaning. Long nails create spaces where bacteria accumulate and resist removal. Rings and bracelets trap moisture and organisms, making effective hand hygiene nearly impossible while wearing them. Standard precautions form the foundation of infection prevention in healthcare, representing the baseline safety measures that protect both patients and healthcare workers from pathogen transmission. The critical concept is that these precautions apply to every patient, every time, regardless of their known infection status. This universal approach exists because we cannot reliably identify all infected patients. Many people carry pathogens asymptomatically, and laboratory tests cannot detect every possible infectious agent. By treating all patients as potentially infectious, we create consistent protective barriers that prevent transmission of both known and unknown pathogens. Hand hygiene anchors every patient interaction, performed before and after all patient contact. This single intervention prevents the majority of healthcare-associated infections, yet it requires consistent execution to maintain effectiveness. Personal protective equipment selection depends on anticipated exposure rather than patient diagnosis. Gloves protect against contact with blood, body fluids, and contaminated surfaces. Gowns provide barrier protection during procedures likely to generate splashes or when caring for patients with multi-drug-resistant organisms. Eye protection and masks shield mucous membranes during procedures that might generate droplets or aerosols. Safe injection practices prevent bloodborne pathogen transmission through proper needle and syringe handling. Never reuse needles or syringes, even on the same patient. Use sterile technique for medication preparation and administration. Respiratory hygiene and cough etiquette minimize droplet transmission. Cover coughs and sneezes, dispose of tissues immediately, and perform hand hygiene after respiratory contact. This becomes particularly important in NICUs, where respiratory viruses can devastate vulnerable populations. Environmental cleaning eliminates pathogen reservoirs on surfaces that patients and staff contact frequently. Regular cleaning and disinfection of bed rails, monitors, and other equipment prevents accumulation of organisms that could transfer to subsequent patients. Safe linen handling prevents shaking or excessive agitation that could aerosolize pathogens. Contaminated linens should be contained at the point of use and handled minimally. Proper waste disposal ensures that infectious materials are contained and processed appropriately, preventing environmental contamination. These standard precautions create the foundation upon which all other isolation precautions build, making consistent implementation absolutely essential for effective infection prevention. Transmission-based precautions represent additional layers of protection beyond standard precautions designed to interrupt specific pathogen transmission routes. These precautions are pathogen-specific and add targeted barriers where standard precautions alone cannot prevent spread. Understanding transmission-based precautions requires recognizing that different organisms spread through distinct mechanisms. Contact precautions prevent spread of pathogens transmitted through direct skin-to-skin contact or indirect contact with contaminated surfaces. Examples include methicillin-resistant Staphylococcus aureus, vancomycin-resistant Enterococci, and Clostridioides difficile. These organisms survive on environmental surfaces and transfer easily through hand contact. Droplet precautions target pathogens transmitted through respiratory droplets generated during coughing, sneezing, or talking. These larger droplets typically travel only 3 feet before falling to surfaces, making spatial separation and surgical masks effective barriers. Respiratory syncytial virus, influenza, and pertussis require droplet precautions because they spread through this mechanism. Airborne precautions address the most challenging transmission route: pathogens that remain suspended in air currents for extended periods. These microscopic particles can travel long distances and require negative pressure rooms and N95 respirators for protection. Tuberculosis represents the classic example, though varicella and measles also require airborne precautions. Some pathogens require combination precautions when they spread through multiple routes simultaneously. Varicella requires both contact and airborne precautions because the virus transmits through respiratory particles and direct contact with skin lesions. Duration of precautions varies significantly by organism and clinical circumstances. Some require isolation until cultures turn negative, others until symptoms resolve, and some have predetermined time periods based on pathogen-specific epidemiology. Clear signage on doors or isolettes communicates precaution requirements to all staff and visitors. This visual reminder ensures appropriate personal protective equipment use and helps maintain isolation integrity. Education becomes essential because precaution effectiveness depends on proper implementation by everyone entering the room. Staff must understand not just what equipment to wear, but proper donning and doffing techniques to prevent self-contamination. Documentation in the medical record ensures continuity across shifts and departments, preventing inadvertent precaution breaks that could expose other patients or staff to preventable infections. Contact precautions represent the most commonly implemented transmission-based precautions in the NICU, designed to prevent spread of pathogens that transmit through direct contact or contaminated environmental surfaces. The organisms requiring contact precautions share a critical characteristic: they survive on environmental surfaces for extended periods and transfer easily through hand contact. Methicillin-resistant Staphylococcus aureus and vancomycin-resistant Enterococci represent classic examples of multi-drug-resistant organisms that colonize patients and spread rapidly through healthcare settings without proper barriers. Clostridioides difficile requires contact precautions because the spores survive on surfaces for months and resist alcohol-based hand sanitizers. This organism highlights why soap and water becomes mandatory rather than optional when caring for certain pathogens. Respiratory syncytial virus, despite being a respiratory pathogen, spreads primarily through contact with contaminated secretions rather than airborne transmission. Infants with RSV shed virus in nasal secretions that contaminate hands, surfaces, and equipment. Similarly, rotavirus spreads through fecal-oral transmission, making contact precautions essential for containing outbreaks. Scabies requires contact precautions because the mites transfer through direct skin contact and can survive briefly on clothing and bedding. The gown and glove requirement creates a barrier between the healthcare worker and contaminated surfaces. The gown protects clothing and exposed skin from contamination, while gloves prevent hand contamination during patient care. Both must be removed before leaving the room to prevent carrying organisms to other patients. Dedicated equipment stays in the room to prevent cross-contamination. Stethoscopes, blood pressure cuffs, and other reusable items remain with the patient rather than moving between rooms. When shared equipment is absolutely necessary, it requires thorough disinfection between patients. Private rooms provide the best isolation, but cohorting patients with the same organism can be acceptable when private rooms are unavailable. Enhanced environmental cleaning uses EPA-registered disinfectants effective against the specific pathogen, with increased frequency of high-touch surface cleaning. Contact precautions continue until patients meet pathogen-specific discontinuation criteria, which varies from negative cultures to symptom resolution depending on the organism involved. Droplet precautions address pathogens that spread through respiratory droplets generated when infected patients cough, sneeze, talk, or undergo procedures that stimulate the respiratory tract. Understanding droplet transmission helps explain why these precautions differ significantly from both contact and airborne requirements. Respiratory droplets are relatively large particles, typically greater than 5 micrometers in diameter, that behave predictably in air. These droplets fall to surfaces within approximately 3 feet of the infected person due to gravity, which is why the 3-foot protection radius becomes the standard for droplet precautions. Pertussis represents one of the most concerning droplet-transmitted pathogens in neonatal care. Bordetella pertussis spreads efficiently through respiratory droplets, and infected adults often present with atypical symptoms that delay recognition. Healthcare workers can unknowingly transmit pertussis to vulnerable neonates who lack protective antibodies and cannot be vaccinated until 2 months of age. Influenza transmission through droplets makes annual vaccination programs critical for healthcare workers. Infected staff can spread influenza to patients, families, and colleagues, creating potential outbreaks in vulnerable populations. The seasonal nature of influenza requires heightened vigilance during epidemic periods. Mumps, though less common due to vaccination programs, still requires droplet precautions when identified. Meningococcal disease represents a medical emergency requiring immediate isolation because of its rapid progression and high mortality rate. The surgical mask requirement within 3 feet of the patient provides adequate protection because droplets cannot penetrate standard surgical masks effectively. Unlike airborne precautions, specialized respirators are unnecessary because droplets do not remain suspended in air currents. Private rooms are preferred but not absolutely required, like with airborne precautions. The door may remain open because special air handling systems are unnecessary. Droplets fall to surfaces quickly rather than circulating throughout the ventilation system. This approach makes droplet precautions more practical to implement than airborne precautions while still providing effective protection against respiratory droplet transmission. The key is maintaining the 3-foot distance and using appropriate respiratory protection during close patient care activities. Airborne precautions represent the most stringent isolation measures we implement in healthcare, addressing pathogens that achieve something particularly dangerous. They remain suspended in air currents for extended periods and can travel long distances before infecting susceptible hosts. To understand why airborne precautions are so critical, consider how these pathogens differ from droplet transmission. While respiratory droplets fall to surfaces within 3 feet, airborne particles are tiny enough, typically less than 5 micrometers, that they behave more like dust particles floating in room air. These microscopic infectious particles can remain suspended for hours and travel throughout entire buildings via ventilation systems. Tuberculosis exemplifies the airborne threat in healthcare settings. When patients with pulmonary tuberculosis cough, they generate tiny droplet nuclei containing viable Mycobacterium tuberculosis organisms. These particles can linger in room air long after the patient has left, potentially infecting anyone who enters and breathes that contaminated air. The infectious dose can be remarkably small. Sometimes just a few organisms can establish infection in susceptible individuals. Varicella, commonly known as chickenpox, requires airborne precautions because the virus spreads through both respiratory secretions and airborne particles from skin lesions. The virus can remain viable in air for considerable periods, making environmental control absolutely essential. Disseminated zoster follows similar patterns because it represents varicella virus reactivation with systemic spread. Measles represents perhaps the most contagious airborne pathogen with an extraordinarily high transmission rate. The virus can remain infectious in room air for up to 2 hours after an infected person leaves, and susceptible individuals can become infected simply by entering a room where a measles patient was present earlier. The N95 respirator requirement reflects the need for specialized filtration that can capture these microscopic particles. Unlike surgical masks that primarily block larger droplets, N95 respirators filter out at least 95% of airborne particles down to 0.3 micrometers. Fit testing ensures the respirator creates an adequate seal against the user's face, preventing bypass of unfiltered air around the mask edges. Negative pressure rooms create controlled airflow patterns that prevent contaminated air from escaping into adjacent areas. These rooms maintain lower air pressure than surrounding spaces, causing air to flow into the room rather than out. The air handling system typically includes specialized filtration and direct exhaust to the outside environment. Central line-associated bloodstream infections represent one of the most preventable yet devastating complications in neonatal intensive care. Understanding how CLABSI prevention bundles work helps us appreciate why each element exists and how they work together to create powerful protection. Think of CLABSI prevention as building layers of defense, with each bundle element addressing a specific vulnerability in the process of placing and maintaining central venous catheters. The beauty of bundle approaches is that even if one element fails, the remaining layers continue providing protection. The insertion bundle focuses on the critical moment when we create a direct pathway into the bloodstream. Hand hygiene forms the foundation because contaminated hands represent the most common source of catheter colonization. Even with sterile gloves, inadequate hand preparation can introduce organisms that later migrate along the catheter tract. Maximal sterile barriers transform the insertion procedure into a true surgical intervention. This means full sterile draping of the patient, not just the insertion site, along with sterile gowns, gloves, masks, and caps for all personnel involved. This comprehensive approach eliminates the environmental contamination that can occur during lengthy procedures. Chlorhexidine skin preparation provides superior antimicrobial activity compared to povidone iodine solutions, but the age restriction for infants over 2 months reflects concerns about potential absorption in very young infants with immature skin barriers. For younger infants, povidone iodine remains the standard while still providing effective skin antisepsis. Optimal catheter site selection considers both procedural success and infection risk. While the femoral site may seem easier to access, it carries higher infection rates due to proximity to the diaper area and increased movement. Subclavian sites generally have the lowest infection rates, followed by internal jugular placement. Daily necessity review prevents prolonged catheter exposure. Every day a central line remains in place increases cumulative infection risk, making prompt removal when no longer essential a critical safety measure. The maintenance bundle addresses the ongoing risks that develop after successful insertion. Hub scrubbing for 15 seconds before each access eliminates organisms that accumulate on connector surfaces. This mechanical cleaning combined with antimicrobial action provides reliable disinfection when performed consistently. Maintaining a aseptic technique during all line manipulations prevents introducing organisms during routine care activities like medication administration or blood sampling. CLABSI prevention in the neonatal intensive care unit requires specialized adaptations that address the unique vulnerabilities and anatomical differences of newborn patients. These modifications ensure that evidence-based prevention strategies remain both safe and effective for our most fragile patients. The age-specific considerations for infants less than 2 months old reflect fundamental differences in neonatal skin physiology. Povidone iodine becomes the acceptable alternative for skin preparation because it provides reliable antimicrobial activity without the absorption concerns associated with chlorhexidine in very young infants. The neonatal skin barrier remains immature, with increased permeability that could allow chlorhexidine absorption into systemic circulation. While chlorhexidine offers superior antimicrobial persistence, the safety profile of povidone iodine makes it the preferred choice until skin maturation reduces absorption risks after 2 months of age. Understanding umbilical line duration limits requires appreciating the unique infection risks these devices create. Umbilical arterial catheters carry a maximum 14-day limit because they access the systemic arterial circulation directly through the umbilical artery. These catheters thread through the hypogastric artery into the aorta, creating direct access to major organ blood supply. Prolonged placement increases thrombotic complications and systemic embolization risks beyond the 14-day threshold. Umbilical venous catheters have an even shorter 7-day maximum duration because they terminate in the inferior vena cava, or right atrium, creating direct access to central circulation with higher infection transmission potential. The umbilical vein also tends to develop thrombosis more readily than arterial access, limiting safe duration of use. The preference for peripherally inserted central catheters over surgically placed central venous catheters reflects both procedural and infectious advantages. PICC lines require less invasive placement procedures, reducing immediate complications and infection risks associated with surgical cut-down techniques. The peripheral insertion site typically has lower bacterial colonization than central insertion sites like the neck or groin areas. Daily assessment of line necessity forms a critical component of CLABSI prevention because every additional day a central line remains in place increases cumulative infection risk exponentially. This daily review process requires systematic evaluation of whether the catheter still serves an essential clinical purpose that outweighs its infection risks. The assessment considers current medication requirements, nutritional needs, blood sampling frequency, and the patient's overall clinical trajectory. The 50% total parenteral nutrition threshold for line removal represents a practical decision point where nutritional benefits no longer justify infection risks. Once caloric needs can be met primarily through enteral feeding, leaving central access in place creates unnecessary exposure to potential bloodstream infections without corresponding clinical benefits. Two-person verification protocols prevent medication errors and ensure proper aseptic technique during line manipulations. Ventilator-associated pneumonia prevention in the neonatal intensive care unit requires understanding how mechanical ventilation creates vulnerability while implementing evidence-based interventions that work within the constraints of caring for critically ill newborns. The concept of VAP prevention centers on recognizing that endotracheal tubes bypass natural upper airway defense mechanisms. Normally, the nose and throat filter particles, warm and humidify air, and trap pathogens before they reach the lungs. When we place an endotracheal tube, we eliminate these protective barriers and create a direct pathway for bacteria to reach the lower respiratory tract. Head of bed elevation between 30 and 45 degrees takes advantage of gravity to prevent gastric contents from refluxing into the respiratory tract. This positioning reduces the risk of aspiration pneumonia while still maintaining hemodynamic stability. The angle range provides flexibility for patient comfort and clinical needs while maintaining the anti-reflux benefit. Daily extubation readiness assessment prevents prolonged mechanical ventilation that unnecessarily extends infection risk. Each additional day on the ventilator increases cumulative VAP risk exponentially. The assessment considers respiratory parameters, hemodynamic stability, and neurologic function to identify patients who can safely transition to spontaneous breathing. Oral care every 4 to 6 hours addresses bacterial colonization in the oropharynx that can migrate down the endotracheal tube. In neonates, this requires gentle techniques appropriate for delicate oral tissues. Interestingly, maternal breast milk can be used for oral care because it contains natural antimicrobial properties and immunoglobulins that help reduce pathogenic bacterial colonization while being completely safe for the infant. Closed suction systems prevent environmental contamination during routine airway clearance. These systems allow suctioning without disconnecting the ventilator circuit, maintaining positive pressure and preventing backflow of secretions. The principle of changing ventilator circuits only when soiled challenges traditional practices that called for routine circuit changes. Research demonstrates that scheduled circuit changes actually increase infection risk by creating opportunities for contamination during the change process. Hand hygiene before and after all ventilator manipulations prevents healthcare worker hands from becoming vectors for pathogen transmission to the respiratory tract. Minimizing circuit breaks reduces opportunities for bacterial contamination of the respiratory system. Antibiotic stewardship in the neonatal intensive care unit represents one of our most critical interventions for optimizing patient outcomes while preventing the emergence of resistant pathogens. This systematic approach requires understanding both the immediate clinical needs and the long-term consequences of antibiotic use. The foundation of antibiotic stewardship centers on the principle of using the right drug at the right dose, for the right duration, via the right route. This seems straightforward, but in neonates, each decision carries heightened complexity because of immature pharmacokinetics, limited drug options, and the catastrophic consequences of treatment failure. De-escalation based on culture results represents perhaps the most important stewardship practice. Once we identify the specific organism causing infection, we should narrow our antibiotic spectrum to target that pathogen specifically. For example, if blood cultures grow group B streptococcus, that's sensitive to penicillin, we should switch from broad-spectrum ampicillin and gentamicin to penicillin alone. This targeted approach reduces pressure on normal flora and decreases the selection of resistant organisms. The 48-hour rule for stopping antibiotics when cultures remain negative requires careful clinical judgment. If blood cultures show no growth after 48 hours and the infant appears clinically well, continuing antibiotics often causes more harm than benefit. This practice prevents unnecessary antibiotic exposure while recognizing that most bacterial pathogens will grow within this timeframe. Avoiding antibiotics when viral infections are suspected reduces inappropriate use that provides no clinical benefit. Respiratory syncytial virus, enterovirus, and other common neonatal viral pathogens don't respond to bacterial antibiotics, yet the clinical presentations can overlap significantly with bacterial sepsis. When viral testing is positive or clinical patterns strongly suggest viral etiology, discontinuing bacterial antibiotics becomes appropriate. Monitoring days of therapy helps track both individual patient exposure and unit-wide antibiotic use patterns. Each day of antibiotic therapy increases the risk for developing resistant organisms, disrupts normal flora, and predisposes to secondary infections like Candida. Keeping detailed records allows us to identify patterns of overuse and implement targeted interventions. Tracking resistance patterns through regular antibiogram updates provides essential data for empiric therapy decisions. Understanding local resistance patterns helps us choose initial antibiotics that are most likely to be effective while avoiding agents with high local resistance rates. This data also alerts us to emerging resistance trends that might require changes to standard protocols. Pharmacy collaboration ensures optimal dosing, monitors for drug interactions, and provides expertise in antimicrobial selection. Pharmacists often identify opportunities for de-escalation, catch dosing errors, and provide valuable input on duration of therapy based on current evidence and institutional protocols. Multidrug-resistant organism prevention in the neonatal intensive care unit requires a comprehensive, layered approach that addresses both the unique vulnerabilities of this population and the complex transmission dynamics of resistant pathogens. Active surveillance forms the foundation of effective MDRO prevention because it allows us to identify colonized patients before clinical infection develops. Admission screening becomes particularly important in NICUs because babies often transfer from other facilities or may have been exposed to antibiotics and resistant organisms during previous hospitalizations. This initial screening helps us implement appropriate precautions from the moment of admission rather than waiting for clinical signs of infection. Weekly surveillance for high-risk patients extends this protection throughout the hospitalization. High-risk patients include those receiving prolonged antibiotics, particularly third or fourth generation cephalosporins that create strong selective pressure for resistant organisms. Extremely low birth weight infants also warrant enhanced surveillance because their prolonged hospitalizations and multiple invasive procedures create numerous opportunities for MDRO acquisition. Outbreak investigation protocols allow rapid identification and containment when MDRO transmission occurs within the unit. The project knowledge emphasizes how methicillin-resistant Staphylococcus aureus and vancomycin-resistant Enterococci can spread rapidly through NICUs via healthcare worker hands, making prompt outbreak recognition essential for preventing widespread transmission. Contact precautions remain the cornerstone of MDRO prevention once colonization or infection is identified. These precautions require gown and glove use for all patient contact, dedicated patient care equipment, and enhanced environmental cleaning protocols. The combination of barrier precautions prevents cross-contamination through direct contact and contaminated surfaces. Cohorting patients with identical MDRO colonization allows more efficient use of resources while maintaining effective isolation. When multiple patients harbor the same resistant organism, cohort nursing can provide specialized care while preventing spread to other patients. Staff cohorting, where specific nurses care only for MDR-O-positive patients during their shift, further reduces transmission risk by minimizing the number of healthcare workers moving between colonized and non-colonized patients. Enhanced environmental cleaning addresses the reality that many MDROs survive on surfaces for extended periods. Vancomycin-resistant Enterococci, for example, can persist on environmental surfaces for weeks, requiring specialized cleaning protocols and EPA-registered disinfectants effective against these organisms. Decolonization protocols, when available and appropriate, can reduce the bacterial load of colonized patients and decrease transmission risk. However, these protocols must be used judiciously to avoid selecting for even more resistant strains. Monitoring compliance ensures that all these interventions function effectively. Regular audits of hand hygiene, proper precaution use, and environmental cleaning protocols help identify gaps in implementation that could lead to transmission events. Environmental controls in neonatal intensive care represent our most basic yet critical line of defense against healthcare-associated infections. Understanding how pathogens survive and spread through the environment helps us appreciate why these controls form such an essential foundation for infection prevention. The concept of high-touch surface cleaning addresses the reality that pathogenic bacteria and viruses can survive on common surfaces for hours to days, creating reservoirs that facilitate transmission between patients. High-touch surfaces in the NICU include obvious areas like bed rails and monitors, but also frequently overlooked items like computer keyboards, door handles, and light switches that healthcare workers contact repeatedly throughout their shifts. Daily cleaning of these surfaces represents the minimum standard, but the timing and technique matter significantly. Cleaning should occur between patient assignments and after any known contamination events. The key principle is that cleaning must include both physical removal of organic matter and chemical disinfection, with EPA-registered products effective against the pathogens commonly found in our unit. Terminal cleaning protocols come into play when patients are discharged or transferred from isolation rooms. This comprehensive process involves cleaning and disinfecting every surface in the room, from ceiling to floor, including areas that might not receive attention during daily cleaning. Think of terminal cleaning as resetting the room to a baseline level of cleanliness that protects the next patient who occupies that space. UVC disinfection has emerged as a valuable adjunct to traditional cleaning methods because it addresses one of our biggest challenges: human variability in cleaning thoroughness. Ultraviolet C light at specific wavelengths can destroy the genetic material of bacteria, viruses, and fungi on surfaces. However, UVC works as a supplement to, not a replacement for, manual cleaning because organic matter can shield pathogens from UV exposure. Monitoring cleaning effectiveness transforms cleaning from a checkbox activity into a quality improvement process. This monitoring can include visual inspection, ATP bioluminescence testing to detect organic residue, or even fluorescent marking systems that reveal which surfaces actually received adequate cleaning attention. Dedicated equipment policies recognize that shared medical devices can serve as vehicles for pathogen transmission. When possible, items like stethoscopes, blood pressure cuffs, and monitoring devices should remain with individual patients rather than moving between rooms. When sharing is unavoidable, rigorous cleaning and disinfection between patients becomes absolutely critical. Toy cleaning protocols address the unique aspects of pediatric care where comfort items and developmental toys may move between patients or become contaminated during care activities. These protocols must balance infection prevention with the developmental and emotional needs of infants and families. Visitor restrictions during outbreaks represent one of our most challenging interventions because they impact family bonding and support systems during already stressful times. However, limiting the number of people entering and leaving patient care areas can significantly reduce the number of potential vectors for pathogen transmission during active outbreaks. Construction infection control becomes essential when renovation or building projects occur near patient care areas. Construction activities can aerosolize fungal spores and other pathogens, requiring specialized air handling, barrier installation, and enhanced environmental monitoring to protect vulnerable patients. Outbreak management in the neonatal intensive care unit represents one of our most critical challenges because vulnerable infants and the unit environment create perfect conditions for pathogen transmission. Recognizing increased incidence requires understanding your unit's baseline infection rates and maintaining vigilant surveillance. This recognition often begins when bedside nurses notice unusual patterns, perhaps multiple babies developing similar symptoms or positive cultures for the same organism. Experienced staff develop pattern recognition that helps identify potential outbreaks before formal surveillance confirms the problem. Notifying infection prevention immediately cannot be overstated because time becomes critical. Each hour of delay allows more transmission opportunities. Infection preventionists bring specialized outbreak investigation expertise and access to resources like microbiology support and environmental health services. Creating a line list provides the foundation of outbreak investigation. This systematic documentation captures essential details: patient identifiers, symptom onset dates, culture results, staff assignments, and potential exposure sources. The line list reveals epidemiologic patterns that might not be obvious when examining individual cases. Perhaps all affected babies shared the same nurse or underwent similar procedures. Implementing control measures must happen simultaneously with investigation rather than waiting for answers. Enhanced precautions typically mean upgrading to contact precautions for all suspected cases, ensuring rigorous hand hygiene compliance, and potentially requiring additional protective equipment. Cohorting groups affected patients in designated unit areas with dedicated nursing staff who care only for those patients during their shifts. This prevents cross-contamination between affected and unaffected patients while allowing specialized outbreak-related care. Visitor restrictions help reduce the number of people moving through the unit who could serve as transmission vectors. While difficult for families, these restrictions have successfully limited nursery outbreaks for highly transmissible pathogens. Environmental and staff cultures may be indicated based on specific pathogens and epidemiologic findings. If investigation suggests environmental contamination or healthcare worker transmission, targeted cultures identify reservoirs and guide decolonization efforts. Daily communication ensures all team members understand current outbreak status, implemented control measures, and protocol changes. This includes bedside staff, physicians, infection prevention, administration, and appropriate family communication. Quality improvement in the neonatal intensive care unit represents a systematic approach to enhancing patient safety and outcomes through continuous measurement, learning, and refinement of care processes. Understanding this methodology helps us appreciate how meaningful change actually happens in healthcare settings. Plan-Do-Study-Act cycles form the backbone of quality improvement methodology because they provide a structured framework for testing changes on a small scale before implementing them broadly. Think of PDSA cycles like scientific experiments applied to clinical care. The planning phase involves identifying a specific problem and proposing a potential solution. The do phase tests this solution on a small scale, perhaps with a few patients or during a single shift. The study phase critically examines what happened during the test. Did the intervention work as expected? What unintended consequences emerged? This analysis phase often reveals insights that weren't apparent during planning. The act phase then decides whether to abandon the intervention, modify it, or scale it up based on the results. Bundle compliance monitoring transforms evidence-based practices from suggestions into measurable actions. Instead of hoping that staff remember to follow protocols, systematic monitoring tracks whether each bundle element actually occurs. For example, in central line insertion bundles, we measure whether hand hygiene, maximal sterile barriers, appropriate skin preparation, optimal site selection, and daily necessity reviews all happen consistently. Real-time feedback makes this monitoring meaningful by providing information when it can still influence behavior. Rather than waiting for monthly reports, real-time systems allow immediate recognition when compliance falters or improves. This immediate feedback loop helps staff understand the connection between their actions and patient outcomes. Celebrating successes acknowledges the hard work that improvement requires, while reinforcing behaviors we want to continue. Recognition doesn't just make people feel good, it communicates organizational values and encourages sustained engagement in improvement efforts. When infection rates drop or bundle compliance improves, celebrating these achievements helps maintain momentum. Learning from failures transforms setbacks into opportunities for deeper understanding. Healthcare-associated infections, medication errors, or protocol deviations become learning cases rather than blame opportunities. This approach encourages transparency and honest reporting that leads to system improvements rather than individual punishment. Multidisciplinary teams bring diverse perspectives that single professions might miss. Physicians understand pathophysiology and treatment decisions. Nurses observe minute-to-minute patient responses. Pharmacists know medication interactions, and respiratory therapists understand equipment challenges. This collective expertise identifies improvement opportunities that any single discipline might overlook. Family engagement recognizes that parents and caregivers observe their infants continuously and often notice changes before clinical staff. Including families in quality improvement efforts through safety reporting, feedback mechanisms, and education partnerships creates additional layers of vigilance for patient safety. Transparent reporting builds trust and accountability by sharing both successes and challenges openly with all stakeholders. This transparency helps everyone understand current performance, improvement goals, and progress toward those goals.